So let's start with the ICD-10 and ICD-11. I will try to cover it as can today. So we did a series in our WhatsApp groups, you know, turn by turn, and I will just go through a summary of everything. So the basic difference in the start, what I have found in the ICD-11 and ICD-10 is ICD-10 was it started from old age and goes to the younger and younger and younger age. While yeah, Muhammad Khalid, very welcome, and it was Muhammad Khalid who requested this, and thank you for joining. So ICD-11 generally goes from birth to the old age, while ICD-10 started from usually, generally, not not strictly, uh, and it's not strictly in either direction, but generally ICD-10 goes from old age to young age, and ICD-11 generally goes from young age to old age. It's just a rough rule, it's not a strict rule, and there are many, many, many exceptions to that rule. Now, so if we see here, let's try to open the ICD 11 in the same window. Sorry, this is ICD 10 in the same window. So this is ICD 10 and this is ICD 11. So if you see ICD 10, it starts from something like so page down, and so I usually one like 0 to 10, it is more of an organic disorders, delirium, and then from 10 to 20 it is substance misuse, then 20 to 30 it is generally psychotic disorders, and then 30 to 30 to 40 it is generally mood disorders, 40 to 50 anxiety disorders, 50 to 60 it is eating disorders, peripheral disorders, 60 to 70 it is personality disorders, 70 to 80 is the learning disability, and 80 to 90 is more kind of autistic spectrum disorders, 90 to 100 is more childhood disorders. So this is the classification, which is ICD 10. And I will just mute your mics, please. Thank you. Please mute it. Thank you. Okay, so so this is how ICD 10 looks like. F40 to 48, and then F45. Yeah. And we're in F50s, 60s. So behavioral personality and behavioral disorders, paraphilias. F70 to 79, it's mental retardation. F80 to 89 is developmental disorders. And F90 to 98 is generally childhood disorders. So it was a very good classification, still very good, but now we have to move on and we have to go through the ICD 11, which has its own pros and cons, and we have to accept it as it is, and it will continue evolving over the time. So what they say is exclusions. Acute stress reaction is no more a psychiatric disorder. If you have to make it a psychiatric disorder, you have to do something else, but it is not in itself it's not a psychiatric disorder anymore. Similarly, physiological or uncomplicated bereavement is no more a psychiatric disorder. Then again, sleep wake disorders, they are no more in the, so all these things are coded elsewhere. We are now in the chapter number 6. Chapter number 6 is mental and behavioral disorders. All other chapters are something else. So here it is QE84, acute stress reaction. It is not in chapter 6, although it is in classification, but it's not in chapter 6. And this is the chapter 6. This is PDF is only for chapter 6, which is mental and behavioral disorder. And when we go to the footer, I will show you what else it is. So sleep wake disorders are in the chapter 7 now. Sexual dysfunctions are in chapter HA. Gender incongruence, it's no more gender identity disorder, so it is coded elsewhere. It is gender incongruence and it is under HA. This block contains neurodevelopmental disorders, so we are starting with the birth, neurodevelopmental disorders. Now we are going to schizophrenia, then catatonia, then mood disorders. So the rest, from birth we go to the teenage and 20s. So we go to the schizophrenia, catatonia, more psychotic disorders in the same way it was F20. Then mood disorders, it was same way it was F20, now like F30s. Anxiety, same order. F40s, obsessive compulsive disorders. So F40s, dissociative disorders was F40s. So we are in the same kind of order. We are going disorders associated with stress, feeding and eating disorders were F50. Now again in the similar order, elimination disorder, disorder of bodily distress or bodily experience, disorders due to substance use or addictive behaviors, and impulse control disorders and disruptive behavior. So impulse control disorder, again, they're around these. Your mic, thank you. And then after that it's the personality disorders, paraphilic disorder, factitious disorder. So we are going in the same order from F20 to F60 or 70. and and then after that it is the disruptive behavior or dissocial disorders, personality disorders, paraphilic disorders, factitious disorder. Now the order which was number 1 becomes the number last, which is the neurocognitive disorder. So the first thing which was organic becomes the last here, and the last thing becomes first, but all other order remains almost the same. Now, mental and behavioral disorders associated with pregnancy, childbirth, and puerperium, this also comes near the organic disorders. So it is the neurocognitive disorders. And then secondary mental and behavioral syndromes associated with disorders or diseases classified elsewhere. So again, secondary means organic, primary means functional, and secondary means organic, because we are going in line with the medicine. So for example, if we are saying primary hypertension, essential hypertension, or hypertension secondary to something else. So similarly here, the idiopathic or primary or essential things will be called primary, or functional will be primary here, and then secondary. So first becomes last, and last becomes first. All other order remains almost the same. Okay, so let's continue. Yeah, and I wanted to show you the footer. So the footer, I said that if you see that ICD 11 MMS 02 2022. So this is the 2022, this month's edition. They have released, and they have added 20 pages to that like it was 183 pages, and now after addition of 22 pages it is like 205 or 207 pages, 207 actually. So 24 pages they have added to the older one, which was May 2021. So they have made changes, and all you have to do is go to the ICD. If we go to the ICDWHO.int, and it is ICD, and then open the ICD 11 browser, and then open with the, and this says version 2022 February, and then open chapter 6, and all you need is there, starting from the birth neurodevelopmental disorder, going to the neurocognitive and organic or the secondary disorders here, and in between it is the same: schizophrenia, catatonia, mood disorder, anxiety. Now in this secondary, I think the substance misuse will also come somewhere, maybe in the secondary. I think it will be in the secondary. So organic, so F0 to 10 has moved to the end, and F11 to 20 has also moved to the end. F80 to 90 and F90 to 99, they have moved in the beginning. Rest remains the same. Chat box, thanks. Can you send the link? Is it the same one I sent? Okay, I will send the link of the ICD 11 right now. Okay, yeah, here is the link to ICD 11, and what you do is usually, you know, I usually do have to do something, you know, some processing before I make it available to you. So what I do is I go to info, then I go to print versions, and sometimes when you click the print version it gives you a zip folder. Then you go for the chapter 6 and it gives you the Word file, and then I convert that Word file into a PDF file, and that's how I made it. So let's go back to the yeah, that's how it looks like, and you're very welcome. And then we go to the, so let's start with this block. So we are doing the first thing first in the life, which is the intellectual development. So primary or not even primary, secondary, but just the developmental things first. So exclusions are dementia. So they are making it clear that they are not taking start with dementia. They're taking start with intellectual development. Disorders of intellectual development: mild, and then moderate and severe, and profound, and then provisional. So before, in the ICD 10, if we go here, it was somewhere here. So let's go to F70 and here. So mild mental retardation, moderate mental retardation, severe mental retardation, profound mental retardation. Now here it is more something else. It is more kind of disorders of intellectual development. It's not mild intellectual disability. It's not learning disability. It is DID, provisional, disorders of intellectual development. Other difference is that in ICD 10 we were saying that if we go to the F70 here, F70, and here it's not coming up and due to some reason. So anyway, so if we are in ICD 10, it was according to the IQ between but less than 50, between 50 and 70, between 70 and 80, between 80 and 90, 31 to 50. So here now in ICD 11 they are not using IQ, and so in ICD 10 there was also exclude. Yeah, there are exclusions in everything. So uh, so let's see here, ICD. Yeah, here we are in 70. uh, yeah, so IQ 50 to 69 mild, IQ 71 F71 is moderate intellectual disability, F 35 to 49, or severe 20 to 34, under 20 it is. Now here they use something else, which is they have complicated, so it has become more difficult to calculate, but who are specialists in this area, they can do it. Or otherwise, you have to go with the psychologist, and psychologists can diagnose, and they know how to use these percentiles. So profound is like 0.0003, sorry, 0.003 percentile, or again severe is below the 0.003 percentile, and 0.003 to 0.1 percentile, and zero point 0.1 to 2.3 percentile is mild. So I would like Dr. Seshni Moodliar to throw some light on it. Please, you can, because it's your subject.
Kamran, I was afraid you were going to ask that. Yeah, no, this is my speciality. So as you said, it is going to be more difficult to diagnose, because obviously before we had the mild, moderate, severe according to the IQ. So 50 to 69 mild, moderate 32. Sorry, mild was 30 to 45. So mild was 30 to 45, and then severe was 20 to 34, and then less than 20, the IQ was profound. And that's the way I worked, and that's the way the teams worked. So obviously we went on the IQ assessments that the psychologist has done. So this obviously, and also the terminology as well, mild, moderate, severe mental retardation, obviously they've changed a lot. And I think, as you said, I think what we will probably need to be doing is taking whatever the values is, they're going to have to look, we will have to look at the graph and the percentile, and then work according to that in the functioning. So it is definitely, I agree with you, it's more complicated. But I think all our assessments will have to change, because what they're saying, yeah, so it's obviously the term has changed as well, it's intellectual development, the disorders of intellectual development. So they've done away with the mental retardation, which, to be honest, is good, isn't it, Kamran?
Yeah. Thank you very
I
much.
think it's a better term. Yeah. So I don't know if anyone else has advice on this, on the percentiles, but I think, as I was saying, it's just going to be according to that. It's going to be very difficult. But I think once we get used to the different percentiles, probably the specific percentile will be allocated a certain number, so certain IQ number, and then according to that. Because what they're saying is, if I just read it, can I just read it quickly? So it says, the disorders of intellectual development are a group of etiological diverse conditions originating during the developmental period and characterized by significantly low intellectual functioning and adaptive behavior that are approximately 2 or more standard deviation below the mean, approximately less than second, third percentile. So based on appropriate named individuals administered standardized tests. So where appropriate named and standardized tests are not available, diagnosable disorders of intellectual development requires greater reliance on the clinical judgment on appropriate assessment of comparable behavioral indicators. So as you can see, it's going to be on the clinical judgment as well. So it's because we're not always going to be able to have someone's IQ test, and that's definitely the experience I've had, and I'm sure a lot of our colleagues as well. Lots of the times sometimes we're not able to get IQ tests. So it is obviously going to be on, again, functioning and clinical assessment. So they're saying that mild disorder of the intellectual disability is a condition originating ensuring the developmental period characterized by significantly below average intellectual functioning and adaptive behavior that are approximately 2 or 3 standard deviations below the mean, so which is 0.1 to 2.3. So usually we have the graph, Kamran. I don't have the graph in front of me, but usually there is a graph that we've always looked at when we've, according to the figures, as I said, the IQ figures will be in accordance to that. So where we've got 50 to 69, so anything under 70, that's where mild started. So it'll be very similar. So it's just that they've changed the IQ number to the percentile number. So it's going to be similar. It will just be that we will have to plot the figure on the percentiles and then on the graph, and then identify that the person is going to fall. If it's 1 to 2.3 percentile, it will go in mild. Can you go further down and then we can go through the other percentiles? So 0.1 to 2.3 will be mild intellectual disability. And then if we look at moderate, 0.003 to 0.1 percentile. So it'll be below that. And then severe will be less than 0.003 and normed. And then profound will be again less than that.
Yeah.
So just going to go further and further down according to the I. So it's basically still similar with the IQ. And they're saying that it's a provisional, so disorder of intellectual development provisionally assigned. Yeah. So yeah, so that's, I think it's gonna be what we know already, Kamran, but it's just that they've changed the figures into percentiles. So that is going to be confusing, and also the terminology. Yeah. So, but obviously they're the same. They've kept mild, moderate, severe, and profound. So it's still the same. It'll just be us converting it. And I think if we've had people already diagnosed as mild, moderate learning disability or mild mental retardation, if we just correlate the percentiles again, that person should still say in the mild intellectual disorder group. And the same for moderate, severe, profound intellectual disorder. Yeah.
Thank you very much, Dr. Seshni. It was very helpful. And again, these things are not complicated at all. As I said, they are complicated things. They're complicated to a degree, but not more than that degree. So things are still the same. It is just they've changed it, and it is. I tell the trainees what is like 97.5% people will have the normal intelligence. So 2.3 in the bottom will have this learning disability. So that's what it is meant by the percentile, that it is less than 2.3 percentile, less than the 22.3rd percentile. That's what it means, that 97% have normal intelligence, and then the 2.5 or 2.3% of the bottom, and then you can make a range in those 2.3 between 0.003 or above, or between 0.1 and 2.3. Yes, Dr. Seshni?
Yes, Kamran, exactly. I think what you're saying. It's not complicated. So I think as I said, for anyone that has existing diagnoses, it will remain the same. So we'll just have to go according to, obviously, just confirm that it falls in those percentiles as you explained. It will be for the new assessments and new diagnoses that we will be making, that obviously people will find difficult initially. So, but I think what the approach as well for what we're doing for intellectual disability and development and disorders, I think it will be similar for general adult conditions, old age conditions, other childhood conditions, eating disorders, anxiety, so personality disorders. So it will all be very similar. It will just be knowing what would be the equivalent disorder that we've had in ICD-10 And then what will it be now in ICD-11? So I think once we all understand that and identify it, it's going to be easy. So I don't think it will be really difficult. It's just for the new diagnostics. I think that's challenging, initially.
Exactly. And usually the diagnosis is made by a neuropsychologist or an educational or clinical psychologist. So they make this diagnosis for you. So, and they know how to calculate the percentiles. It's their bread and butter. And if you don't have those provisions, then you have this option 6A00.4. You can go with the provisional diagnosis. So you can say it's provisionally mild or provisionally moderate, or it's a intellectual development provisional until you have the evidence of a final diagnosis. So if the child is an infant or child under the age of 4, it's not, or it is not possible to conduct a valid assessment, then you can even make a provisional diagnosis. But you have to have at least some experience to make that diagnosis. You have seen loads of patients with mild, moderate, severe, and profound learning disability, and then you can make an idea this should lie in the severe or profound, and you can even then give a range. It could be mild to moderate, or moderate to severe, or severe to profound. So next is developmental speech and language disorders. So it is the same, just the terminology is different. Speech fluency disorder, is language disorder. So we'll just run through these terminology. Now come to 6A02, autism spectrum disorder. It was childhood autism. Here in ICD-10, it was childhood autism. We go to 84. So now it is autism spectrum disorder. Yeah, childhood autism. And now it is autism spectrum disorder. Now if we go to 85 in ICD 11. So F85, yeah, 84.1 is atypical. F84.1 is again atypical, and F then they are talking about the cause, which is not something to be said in the diagnosis for a single cause and excluding all the other causes. So they have corrected that in the ICD-11. And now if we come to F84.4, F84.5, Asperger syndrome. Now there is no more Asperger syndrome in ICD-11. So what happens is that Asperger syndrome, it's all kind of they just go very scientifically now. So they say autism spectrum disorder without disorder of intellectual development, means there's no DID, and the language is normal. So no DID and language is normal with mild or no impairment of functional language. That was the Asperger syndrome, where the language was normal and intellect was normal, but the patient or the child did suffer from the autism spectrum disorder. So, but it was, some people would, it will complicate what is Asperger, what should I call, what should not I call. So it's very easier. Now, instead of saying Asperger, you will say autism spectrum with no language impairment, with no intellectual developmental disorder. It will be equivalent to Asperger syndrome. So it's autism spectrum disorder. Criteria are the same. Autism spectrum disorder with disorders of intellectual development and with mild or no impairment of uh, functional language. So language is normal, but there is a DID. There is a disorder of intellectual development, maybe some mild learning disability. So it will be here. Then the next is autism spectrum disorder without disorder of intellectual development and with impaired functional language. So without disorder of intellectual development, so the person may be genius, but there could be some impaired functional language, or there could be some delay in language. And it is said about one of the great scientists who was who made many achievements. It is said that he started speaking at about 7 years of age, but he was very intelligent. So he would, if that is true, then he will come under this category. Then it will be autism spectrum disorder with disorder of intellectual development and with impaired functional uh, language. So here it both are affected. So there is mild to moderate or severe or intellectual disability as well, and language impairment as well. So they've gone very systematic and very scientific now. And then here it was impaired. It could even be absent functional language. Patient may be mute totally, and that will be classified here. Developmental learning disorders. So learning disorder means that learning something. Autism is something, global learning. No, not in autism. The intellectual disability is about global learning. But here it is specific learning. So they may have reading difficulties, dyslexia, mathematics, and so on. Developmental motor coordination disorder. I don't think it was there in ICD 10, but it was always in DSM 4 and DSM 5. They have introduced here now. So DCD, developmental coordination disorder. Here it will be DMCD, developmental motor coordination disorder. And it can be comorbid with intellectual disability or autism spectrum disorder, or it can occur on its own. So that's a new thing. Now, ADHD, attention deficit hyperactivity disorder. Uh, so 6A05. Again, it was hyperkinetic disorder in ICD-10. Now it is ADHD. The rest is the same. ADHD predominantly inattentive or predominantly hyperactive impulsive. Hyperactive and impulsive are now one domain, and inattentive is the other domain, or combined. Stereotype movement disorder. Again, it was, I think, more. It was something else, but now it is more tic disorder. Sorry, exclusions are tic disorders, trichotillomania. So it was not there. It was only described in context of autism that stereotype movements can occur. But now you can have an uh, additional category of stereotyped movement disorder. And uh, so stereotyped movement disorder without self-injury, so they are different to the tics. They are stereotyped movement disorder with the same thing happening in context of learning disability or autism, which is, if we go with, characterized by the persistent presence of voluntary, repetitive, stereotyped, apparently purposeless, and often rhythmic movements that arise during the early developmental period, not caused by direct physiological effects of substance or medication, and markedly interfere with normal activities, result in self-inflicted body injury. So persistent, lasting several months, presence of voluntary. It says voluntary, repetitive, stereotyped. So that is the key difference. The tics are, to some extent, they are involuntary. So they are semi-voluntary. Here they are voluntary. So stereotype movement disorder without self-injury or with self-injury. Neurodevelopmental disorders unspecified. So now you might have seen that, like, the substance misuse has been skipped, so it will come into towards the end now. So schizophrenia first episode. Now I won't go into the details of criteria, so you can read it, but I think what it is schizophrenia is more than 1 month. It remains I think it's more than, let me see here. So schizophrenia first episode, and yeah, must have persisted for at least 1 month in order to make a diagnosis of schizophrenia. But on another end, it says 3 months, because when it comes to acute and transient psychotic disorders, they say it may persist up to 3 months. So I will just say first episode psychosis till 3 months and not diagnose schizophrenia, because there is an overlap between first episode psychosis and schizophrenia. And after 3 months, I will give the diagnosis, although here it says 1 month. Schizophrenia can be first episode currently symptomatic, first episode in partial remission, first episode in full remission. So this is how they classify. And schizophrenia then multiple episodes. So it was very difficult to diagnose the first episode psychosis. They have made it easier. If it is more than 3 months, rather than causing it first episode psychosis, you can call it first episode schizophrenia if it fulfills the criteria. Otherwise, you will say that acute and transient psychotic disorder, and it will still be first episode. So schizophrenia multiple episodes, whether they are symptomatic, in partial remission, full remission, schizophrenia continuous, and schizophrenia continuous currently symptomatic. And so I think we'll go for another 20 minutes and we'll continue it, after that we'll continue it every week. Maybe in the same, the previous, the 10 o'clocks, the slots will be given to ICD 10 and 11 from now on, and we'll continue the Maudsley prescribing guidelines later on in the course of time. So schizoaffective disorder is another thing. It's again, it can be first episode and then it could be multiple episodes. If there are both symptoms in the same episode, you will call it schizoaffective disorder, and it could be symptomatic, partial remission, or full remission. You're very welcome. And then schizoaffective disorder continuous. So here it was schizophrenia. It was kind of schizophrenia multi-episode or schizophrenia continuous. So it's much more clearer than ICD-10. All you have to know is that you have to memorize the codes once again. And again, if you go with the code, it was F20, and now here it is 6A20. So for schizophrenia, they have made it very easy. That you just say 6A20 and that is schizophrenia. Or if it is, it was F25 for schizoaffective, now it is 6A21. Now, schizotypal disorder. So it stays as the same, as in ICD-10. Acute and transient psychotic disorder. It was, 15 days and up to 1 month. But now it is 15 days and it should not exceed 3 months. And that's why I'm saying first episode schizophrenia, hold off the diagnosis till 3 months and then give the diagnosis after that. Before that, just treat it as a first episode acute and transient psychotic disorder. That's what you should treat like. Or if there are more than one acute and transient psychotic disorder, each time less than 3 months, then you can call it multiple episodes. Same way, full remission, partial remission, symptomatic, and then you go for the delusional disorders the same way, 3 months. In ICD-10 it was 3 months as well. Could be depressive, manic, mixed to mood, in the absence of depressive episode, absence of manic episode, or mixed mood episode, and it's only delusion. And sometimes there can be hallucinations, along that delusions, but usually it's only delusions. And if there are hallucinations, it will be thematically related to that delusion and are still consistent with diagnosis. So if you're seeing more kind of bizarre kind of hallucinations and non-contextual hallucinations and more kind of formal thought disorder, then go with schizophrenia. Delusional disorder, currently symptomatic, partial remission, full remission. Uh, so the same way or unspecified. Symptomatic manifestations like following the DSM-5, they have tried to uh, do something along the same lines. So symptomatic manifestations of primary psychotic disorders. So they say positive symptoms. So you have already diagnosed it was schizophrenia, or you have already diagnosed that it is schizoaffective disorder, you have already diagnosed it was schizotypal disorder, you have already diagnosed it was acute and transient psychotic disorder, you have already diagnosed it was delusional disorder. Now you will say it was positive symptoms in primary psychotic disorders. So you will say it is predominantly positive symptoms, or it may be negative symptoms in primary psychotic disorder. And here it will determine your treatment. If there are more positive symptoms, you will use something like haloperidol or olanzapine or risperidone. If there are more negative symptoms, you will use more aripiprazole. If there are only negative symptoms, you might go for cariprazine. So that's why it is more important to subcategorize anything, whether it was schizophrenia or schizoaffective disorder. Mainly these two. Okay, depressive mood symptoms in primary psychotic disorders. So sometimes there can be mood symptoms and manic mood symptoms in primary psychotic disorder. So sometimes you will diagnose that in as a schizoaffective disorder, but sometimes you will just say that it doesn't fulfill the criteria of schizoaffective disorder. You will just say uh, like depressive mood symptoms in primary psychotic disorders. Uh, Psychomotor symptoms in primary psychotic disorders. So there can be like, for example, purposeless behaviors, fidgeting, shifting, fiddling, inability to sit or stand still. So you can say something like, in addition, the patient can have this as well. And then cognitive symptoms in primary psychotic disorders. So there can be cognitive symptoms in primary. So this is all, it is schizophrenia, but there are some depressive symptoms. Not, patient doesn't fulfill the criteria of schizoaffective disorder or some manic mood, and maybe it is not consistent with the schizoaffective episode. Maybe it's happening separately or after resolution of symptoms, or there can be catatonic symptoms. Then you use these additional terms. Cognitive symptoms, you can use the coding now. Before that, you will just say that there are depressive symptoms, but there were no codes. Now there are codes as well. And then unspecified. Catatonia. Previously, it was catatonic schizophrenia, but now we know that catatonia can be associated with substance misuse. Catatonia can be associated with mood disorders, mania. Manic stupor is a catatonic state, for example. Delirium can result in catatonic features. Schizophrenia can result in catatonic features. Severe depression can result in catatonic features. Dissociative disorder can result in catatonic features. So catatonia in itself is a diagnosis now. So you can say schizophrenia plus catatonia, 6A20 plus 6A40, for example, if it fulfills. So with another mental disorder, so most likely it will be schizophrenia. It can be due to substances, medication, and it could be unspecified. And usually we use the Bush-Francis catatonia rating scale. Mood disorders. So the mood disorders could be bipolar or related mood disorders. Bipolar type 1 and type 2 are separated now. Now they will say type 1 disorder, current episode mania without psychotic symptoms in the same way as ICD-10, or with or without psychotic symptoms, or it could be hypomania. So hypomania, if it is hypomania, then there will be no psychotic symptoms. It has to be mania with psychotic symptoms. If there are psychotic symptoms, you will say it is mania. So bipolar type 1, current episode could be mild or moderate or severe. Now you see the difference here. Moderate depressive episode may be with or without psychotic symptoms. Before, in ICD-10, disorder has to be severe in order to fulfill the psychotic symptoms. But now it is no more necessary uh, to go for severe depressive episode. And in practice, we do see patients of moderate depression with psychotic symptoms. So it's an improvement. So we can just say that it is a bipolar, or we come to the recurrent depression and it is a current episode depressive moderate without psychotic symptoms or moderate with psychotic symptoms. Similarly here, episode depressive severe with or without psychotic symptoms. Bipolar type 1, current episode depressive severe with or without psychotic symptoms. So it's severe with or without, or unspecified. Okay, so I think it was in the beginning, so we are on the 27th page. Okay, so let's go in the beginning, and I think Dr. Naseem asked something about exclusion. So exclusion is generally about any disorder that we should not bring another disorder in the same category. For example, they are excluding dementia. They are not excluding dementia from the whole classification. They are saying that dementia cannot be diagnosed under 6A00. So dementia will be classified elsewhere in the system. And they have told already what they have excluded from the whole classification. Mainly acute stress reaction and uncomplicated bereavement, and coded elsewhere are also kind of exclusions from this chapter 6. So this is meant by exclusion. So 27, go back to, so yeah, so bipolar type 1 is usually there can be hypomania or mania, but there should be at least one manic episode to make it bipolar type 1. There can be subsequent episodes hypomanic. So as it says hypomanic here, but it will still remain bipolar 1. Bipolar 2 is that there is no manic episode. It's only hypomania or depression of, or hypomania and depression of any severity. So it could be, so let's go to the bipolar type 2. So bipolar type 2 is mood disorder by the occurrence of one or more hypomanic episodes or at least one depressive episode. So it's all hypomania, no mania. While depression can be mild or moderate without or with psychotic symptoms, severe with or without psychotic symptoms. That is bipolar type 2. And we'll complete the mood disorders today at least and carry on with the next. So cyclothymic disorder, it's the same, and ICD-10, no difference. Now we come to the depressive disorders. So single episode depressive disorder, it was used to be called depressive episode, but there was no term of disorder associated with that. Now it is called disorder. So single episode depressive disorder And now it could be mild, moderate without psychotic symptoms, or moderate with psychotic symptoms. Again, severe without psychotic symptoms, severe with psychotic symptoms. Now you note they are not talking about somatic syndrome anymore, because somatic syndrome, what does it mean? It happens nearly in more than 90% of depressed individuals anyway, and it doesn't have a diagnostic significance. So you just say, if you go to the ICD website, it now gives you the criteria as well. Just like the Green Book is a criteria based A, B, C, D. So this latest February edition, only website edition, gives you some criteria, diagnostic requirements. It is just added this month. Before that, it used to end here. That's it. So this all orange thing came here now, and hopefully they will come with some another diagnostic criteria made edition, based edition as well. So so that's what they say, concurrent presence of at least 5 of the following characteristics. So they're making it easier. So what I would say is, if you want to really go for the diagnosis, consult the website. This PDF is not enough, because the PDF of this ICD-11 doesn't have the criteria. So if you have to diagnose via criteria, go and search for X6A70.3 and it will give you the diagnostic criteria. It's become, ICD-10 was equally good, and this is ICD-11 is also very good. Single episode depressive disorder, severe with psychotic symptoms. Single episode depressive disorder, unspecified. So for criteria, either read the description. Still not clear, go to the website and go through the criteria. Partial remission, full remission, and sometimes we just go with our clinical judgment and just diagnosed with mild and moderate. That's why or severe, because that's why they don't give criteria and description, to make things easy for us, and we can make diagnosis based on our own clinical judgment. So DSM-5, you have to go through the criteria. In ICD-10, you have the option. It is better if you go through the criteria, but if you have less time, you can just go with the main symptoms and use your clinical judgment. Recurrent depressive disorder, again, mild, moderate without psychotic symptoms, moderate with psychotic symptoms, and severe with psychotic symptoms, severe without psychotic symptoms. And then another thing, in partial remission or full remission, they will tell you. Dysthymic disorder, again, it says 2 years or more. So if the person is depressed for most of the day, but they don't fulfill the criteria of a major depressive disorder, or not at least going through the moderate depressive episode, then you can say it's a dysthymic disorder. Mixed anxiety and depressive disorder, it's the same as in ICD-10, that not meeting the criteria of either depression or anxiety. Prominent anxiety symptoms in mood disorders. So yeah, that's another, I don't know, DSM-5, they use a term, something as an add-on. So here it is the same thing as an add-on. So you can say add-on anxiety symptoms in mood episodes. You can give it a code if you want. That's your provision you have. Panic attacks in mood disorder, you can code them now. Previously you could describe, but you couldn't code. Now they have a code, separate code in addition to the primary code. Current depressive episode persistent. Current depressive episode with melancholia. So current depressive, again, it is the same as severe depressive episode. So if you want to add the term melancholia, you can. Otherwise, if you want to just, current depressive episode persistent. So what I was saying, in dysthymia, it was kind of mild depressive episode picture. you know, or not fulfilling the criteria, but just low mood, and it was more than 2 years. Sometimes you see moderate to severe and it is lasting more than 2 years. You can't say it is dysthymia and ignore it. You have to treat it. And especially in the UK and Ireland, uh, ladies coming from Asia, Pakistan, Bangladesh, India, they are very submissive, and then sometimes they don't get treated for years and years. There's lack of awareness, and they may be, and I find them severely depressed for more than 2 years. I don't say that they are dysthymic. I say it's a prolonged depressive episode, and this category was not there in ICD-10, and thank God we have this category now. The current episode depressive, and current depressive episode persistent. Melancholia, again, the same as moderate to severe episodes, or you can say more biological features involved melancholia, somatic syndrome. Seasonal pattern, yeah. So seasonal pattern of mood episode in onset. If there is no kind of consistent seasonal affective disorder, you just say there is a seasonal pattern. It's better to say additional seasonal pattern rather than saying seasonal affective disorder. Rapid cycling, again, it is something in bipolar 1 and bipolar 2. So there's a high frequency of mood disorders. So usually it was said in the ICD-10 4 or more, and I think it should be the same here as well. And then uh, mood disorder unspecified. So this is the end of 6A group, and we'll start with 6B group or 6B block next week. Time will not be the same. It will be 10 a.m. in Dublin and UK, and it will be 3 p.m. in Pakistan and 3:30 p.m. in India. So thank you very much all for attending, and we'll meet next week. And Dr. Moodliar, you want to say anything?
Oh, I was just going to thank you so much. It was really good and very helpful because we've been talking about this in our peer supervision, and a lot of it's in our topical discussion looking at the differences with ICD-10 and 11. I don't know, Kamran, do you know whether there's training going on in terms of doing the ICD-11 training for us to use it?
Yes, there is training, and the Royal College training. It does happen, and there will be links. So,
Okay,
any other
because I think
question?
usually there should be training, isn't it, for us to be able to use it as well?
No, there are no training. There is a day, but it's more of an academic, kind of know-how. So you
Yeah.
don't have to be trained as long as you can read and diagnose. You can start using it. I don't know if your trust allows it, and if NHS allows, or the health service executive allows, then you can start using it.
Okay. No, thank you very much, Kamran. It was really helpful. Thanks so much. I'll see you next week.
And any other question before we finish the recording?
No, it was just about the training and in terms of how to use it, because so it came up in our peer group with medico legal work. What to sort of use ICD-11, and some people are saying, so there was a bit of a view that some people had started using it, but other people hadn't started using it because they said even though it's come into effect from January 2022, some were not sure whether they should start using the diagnoses.
All right, thank you very much. And chat box, is it necessary to remember codes? No, you don't have to remember the codes. All you have to do is go to icd.who.int international, and then ask for just or open your PDF file and look for anxiety, and it will tell you the code. it took me 20 years to remember the ICD 10 codes, and now it is changed. So it will take years and years before you will be able to remember the code. It's not necessary, but you should know the structure, main structure, how it is. And it is a good practice to go through the criteria to the website or to the PDF and search for and document the code after looking into the book or the website. That's the only way you can remember it over the years.
Yeah, that's a good question, because it used to be so easy to remember it. Now we have to learn new codes.
Yep.
It was really easy to remember it, isn't it? As Kamran, you were saying, it took us years to learn it, and now we have to learn new codes and the differences. Yeah, thank you so much. That's a really good question.